Today I will show you how to examine trachea first, followed by auscultation of respiratory system. This video is only for the first year MBBS students. As a beginner, you have to know how to palpate the trachea, position of the trachea, you have to show the trachea, and you have to auscultate the respiratory system also. Now first I am showing the palpation of the trachea. Trachea usually lies in the central in position. Normal healthy subject, it lies in the central position. See, this is the sternocleidomastoid muscle. This is suprasternal. This portion is the suprasternal notch. This is the head of the sternal head of the sternocleidomastoid muscle. This is another head of the sternal head of the sternocleidomastoid muscle on both sides of the suprasternal notch. And this is trachea, and trachea goes behind the sternum at the suprasternal notch. So, during palpation of the trachea, what you have to do, you have to first make the subject straight, chin in the midline, expose the trachea first, take the consent, stand on the right hand side of the subject, proper illumination, proper exposure of the area to be examined. Now I am examining trachea. With the help of middle finger, first palpate the trachea. Then index finger and ring finger should be at the suprasternal notch in between the sternal heads of the sternocleidomastoid muscle. This is the one head of the sternocleidomastoid muscle, and this is another head of the sternocleidomastoid muscle. So, what I am doing? First, I am palpating the trachea, that is, I am fixing the trachea. Now, I am insinuating both the fingers in between the trachea and the sternal head of the sternocleidomastoid muscle. See, my fingers are insinuating on both sides equally. If this, that means trachea is central in position. This is normal findings. In normal subject, trachea will be in central position. So, what you have to do first, you have to palpate the trachea, fix the trachea, make the subject straight, chin at the suprasternal notch, and fix the trachea. Now, with the ring finger and index finger at the suprasternal notch on both sides of the sternocleidomastoid muscle, trachea, and in between the sternocleidomastoid muscle, sternal head of the sternocleidomastoid muscle, and see whether both the fingers are insinuating equally or not. If you see the one finger is insinuating more than the other finger, that means trachea is shifted to the other side. If the trachea is shifted to the left, that means right index finger has gone more and ring finger has gone less. That means trachea has shifted to the left. That means mediastinal shifting. It indicates mediastinal shifting. If there is mediastinal shifting, that is trachea is shifted to the left, you have to confirm it by the palpation of the apex pit. Then apex pit will also shift to the left. And if you see that trachea is shifted to the right, that means the left finger, that is a left side, left Indian ring finger, my ring finger is going more on the left side, less on the right side. That means trachea is shifted to the right. That means apex pit will also shift. Mediastinal shifting is there. You have to confirm by the palpation of the apex pit. So tracheal shifting, if there is tracheal shifting, you have to confirm it by the palpation of the trachea. If there is shifting of the apex pit while doing the cardiovascular system examination, then also shifting of the apex pit is also confirmed by the palpation of the trachea. This is how to examine trachea. Tracheal shifting denotes mediastinal shifting, and there are so many causes of that. I knew that. I am not going to the theory part. Now I will start the auscultation of respiratory system. First, I am taking the consent of the subject. Now, proper illumination. I am standing on the right hand side of the subject and proper exposure of the area to be exposed. As the lungs is on both sides, in the front, on the sides, and on the back. So you have to, while examining the respiratory system, you have to examine the front and the sides and the back. This is clavicle. See, this is clavicle. So above the clavicle, this is supraclavicular region. Here is also above the clavicle, this is supraclavicular region. The supraclavicular region corresponds with the apex of the lung. This is apex of the right lung, this is apex of the left lung. Now this is the clavicle. Below the clavicle is the infraclavicular region on both sides. So infraclavicular region corresponds with the rest of the upper lobe of the lung. Inframammary region on both sides, it corresponds with the rest of the lower lobe of the lung. So while doing any inspection, palpation, percussion, auscultation, you have to do the anything, you have to do the corresponding area of the opposite side. Always compare with the corresponding area of the opposite side. Now, while examining the axillary region, you have to ask the subject to put the hands like this so that the proper exposure of the axillary region. The lower border of the lung in the mid-clavicular line is in the 6th rib, in the mid-axillary line it is the 8th rib, in the scapular line it is the 10th rib. This is above 5th rib, this is axillary region, it corresponds with the upper lobe of the lung, this is axillary region, this is axillary region, infra-axillary region below the 5th rib, infra-axillary region below 5th rib corresponds with the lower lobe of the lung. Now, back. You do like this. See, you do like this. So there should be proper exposure of the back. This is suprascapular region. This corresponds with the apex of the lung. This is suprascapular region, corresponds with the apex of the lung. This is the interscapular region in between the vertebral column and the scapular line. This is suprascapular region, interscapular region. This interscapular region corresponds with the hilum, and at the angle of below the angle of the scapula, below the angle of the angle of the scapula, angle of the scapula, this infrascapular region corresponds with the lower lobe of the lung. So on back, suprascapular region, interscapular region, infrascapular region. Now, I am showing how to examine the auscultation of the respiratory system. This is chest piece. You have to do like this first. When you are getting the sound, place it over here. Usually shashna. The supraclavicular region, I am examining that supraclavicular region is on the opposite side. Area of the corresponding area. Infraclavicular region and infraclavicular region of the opposite side. Inframammary region and inframammary region of the opposite side. Now axillary region, axillary region. Infraaxillary region, infraaxillary region. Do it like this. Suprascapular region, why I am examining the corresponding area of the opposite side? Because the findings on the corresponding area of the opposite side will be same, but findings of the supraclavicular, infraclavicular will differ, and infraclavicular, inframammary findings will differ, but the corresponding area of the opposite side findings will be same. So you have to examine the auscultation of or anything and the corresponding area of the opposite side in both the 8 areas. Suprascapular, suprascapular, infraclavicular, infraclavicular, supraclavicular, supraclavicular, infraclavicular, inframammary, inframammary, axillary, axillary, infraaxillary, suprascapular, suprascapular, interscapular, infrascapular, like this. Now, after auscultating these 8 areas, what you will see? What is audible? You will audible vesicular breath sound. Vesicular breath sound is like this. This is inspiration. This is expiration. This is expiration. See, the full duration of inspiration will be audible. Full duration of the inspiration, just like you are inflating a balloon. So, like this. Full duration of inspiration will be audible. Now you just drop the balloon. Then what will happen? First, gush of air will exit from the balloon. So, immediately you will only first 1/3 part of the expiration will be audible. This is called vesicular breath sound. So vesicular breath sound is full duration. Say full duration of inspiration, it is an active process, so full duration of inspiration will be audible. Only first one third part of expiration will be audible. There is no gap, it is a continuous process. But expiration will persist because it is a passive phenomenon, but it will be remain inaudible. So this is vesicular breath sound. Now what will be my findings? I will mention vesicular breath sound is audible in equal intensity in both supraclavicular region. Vesicular breath sound is audible in equal intensity in both infraclavicular region. Vesicular breath sound is audible in equal intensity in both inframammary region. Vesicular breath sound is audible in equal intensity in both axillary region. Vesicular breath sound is audible in equal intensity in both infra-axillary region. Vesicular breath sound is audible in equal intensity in both suprascapular region. Vesicular breath sound is audible in equal intensity in both interscapular region. Vesicular breath sound is audible in equal intensity in both infrascapular region. This is my first findings. And next point, as the subject is normal, I am not taking any other points, but you have to mention. Now, the second point is, this will be, you will able to find out, the vesicular breath sound is best heard in the infraaxillary and infrascapular region. Infraaxillary and infrascapular region. So first, vesicular breath sound is audible in equal intensity in the corresponding area. You have to mention the 8 areas. Second point, it is best heard in the infraaxillary and infrascapular region. Third point, there is no additional sound like ronchi, which is a continuous musical sound, mostly audible in during expiration. It is found in case of asthmatic bronchitis or asthma. And capitations or rals, capitations, that is called crackling sound or bubbling sound. If the respiratory tract is full of inflammation, inflammatory exudate, then we will get the crackling sound or bubbling sound. And after that, if there is no crackling sound, bubbling sound, if there is inflammation in between the two layers of pleura, you will get the pleural rubbing sound, like this rubbing sound. But how to differentiate between the pleural rub and the repetitions? You ask the subject to cough. Then what will happen? There will change in position of the repetitions in case of repetition, but no change in position of the pleural rub. Pleural rub will persist and in the same region. And the capitation, if they will find capitation over here, second, ask the subject to cough, it will go to up to here. So change in position of crepitations after the coughing. Now, fourth point is you have to mention, you haven't seen any clinician to place the chest piece of the stethoscope over the trachea, but here we will do it as a on fourth point, not from the beginning. As a fourth point, we will place it over the trachea. Sashna. Now, what is audible? We are bronchial breath sound is audible. This is called bronchial breath sound. Bronchial breath sound. Here, what is happening while subject is breathe in, then gush of air is entering through the trachea. So there is turbulence. So high pitched sound is audible. This is inspiration. This is inspiration, and the full air is going to the tracheobronchial tree up to the alveolus, and then gaseous exit in the capillary level. Then the full uh, carbon dioxide and other gases are from through the tracheobronchial tree is coming to the trachea, and again there is turbulence, and then again we will get the full duration of expiration will be audible. The full duration of inspiration audible, and then there's a definite gap is there. Then there is a definite gap in case of bronchial breath sound. Now why we are auscultating this bronchial breath sound? To train our ears how the bronchial breath sound is audible. If you find any bronchial breath sound in any of the 8 areas, that means there is a consolidation of the lung. Consolidation means like this, lung and with a patent bronchus. This is consolidation. In case of consolidation of the lung, that means pneumonia like this, then what will happen is patent bronchus. We will get the bronchial breath sound over here. We will get the bronchial breath sound. So to train our ears, whether the bronchial breath, if the bronchial breath sound is audible anywhere over this 8 region, there is concentration of the lung with the patent bronchus. Then to train our ears, how the bronchial breath sound is look like or audible, we are placing our chest piece of the stethoscope over the trachea. This is the fourth point. Now I have mentioned, I will first show you I will show you the auscultation of respiratory system. So fifth point is left, that is the vocal resonance. What is vocal resonance? I will ask the subject to utter nasal intonation of sound like 999, 99, 99, 99 or 111 like that. And the vibrations I will get over here with the help of chest piece.
111.
This is supraclavicular region.
111.
This is infraclavicular.
111.
Infraclavicular the opposite side.
111. 111.
Inframammary.
111.
Inframammary.
111. 111.
Infraxillary.
111. 111.
Suprascapular.
111.
Suprascapular. Interscapular. Interscapular. Infrascapular. Infrascapular. The sound he is uttering through the vocal cord is coming via the tracheobronchial tree, and we are picking up via this chest piece to our ear. In normal subject, in the corresponding area, the intensity of the sound will be equal. So fifth point will be vocal resonance is audible in equal intensity in both supraclavicular region. Vocal resonance is audible in equal intensity both infraclavicular region. Vocal resonance is audible in equal intensity both inframammary region. Vocal resonance is audible in equal intensity in both axillary region. Vocal resonance is audible in equal intensity in both infraaxillary region. Vocal resonance is audible in equal intensity in both suprascapular region. Vocal resonance is audible in equal intensity in both interscapular region. Vocal resonance is audible in equal intensity in both infrascapular region. That means if the vocal resonance is normal in sound, that in corresponding area there is no pathology is there. But in some cases of consolidation, if there is consolidation, vocal resonance will be increased. Vocal resonance is solid, so it will transmit more sound. The vocal resonance will be increased in that case. In case of pleural effusion, any side pleural effusion, above the level of the pleural, that means fluid in between the two layers of pleura, and it is pushing the whole of the lungs. When above the level of the fluid level, we can hear some whispering tetralogy or egophony. That means something is whispering in our ear. That is called whispering tetralogy or egophony. That is the nasal intonation of sound may be audible in case of pleural effusion. That is the pathological case. So here, examiner 5 points. If the examiner will ask you to examine the respiratory system, you have to mention first the vesicular breath sound is audible in equal intensity in all the regions, 8 regions you have to mention. Second point, it is best at infraaxillary infrascapular region. Third point, no additional sound like pleural draft, repetitions and rhonchi. Fourth point, bronchial breath sound is audible over the trachea. And fifth point, vocal resonance is audible in equal intensity in all the 8 regions you have to mention. Now, examiner might ask you in right infraclavicular region, can you hear any special sound? Okay. Bronchoviscum, here the character of the breath sound may be in the right, second intercostal space or right interclavicular region. Character of the bronchial breath sound may be bronchovesicular in nature. That means it is mixed with bronchial and vesicular breath sound because right bronchus is more superficial and more close to the apex. In that case, full duration of inspiration will be audible, full duration of expiration will be audible, no gap will be there. Why you are not auscultating this bronchovesicular breath sound in the left side? Because lung is separated from the this systole by the aorta. Lung is separated with the structures like aorta, esophagus, like that. And the at the root of the lung, in the back, it is the interscapular region, and in the front it is the manubrium sterni, where the larger bronchus enters into the through the hilum, two large bronchi. So, in both interscapular region, bronchial breath sound may be audible. It should be audible actually, but we cannot hear the bronchial breath sound over here, normal cases. But it should be audible if examiner asks you, can you hear the, in which area you will be able to auscultate the bronchial breath sound? In normal subject, that will be interscapular region, both interscapular region. So this is your, and at the bronchovesicular vesicular, I have already mentioned in the right infraclavicular region. This is your findings. So the, if you are asked to examine the only auscultation of breath sound, then first 4 points. If you are asked to examine the auscultation of the respiratory system, you have to do the vocal resonance also. That is, you have to mention the 5 points. Okay, thank you.